Okay guys, Timmy coming at you again. And this video goes out to Sarah, who emailed me and asked me if I could talk to her about some arrhythmias. So Sarah, this is for you. Okay, look, when you're going to learn about arrhythmias, right, kind of goofy beats in the heart, first of all, you have to understand the normal EKG, right? So this is basically the normal EKG. And when you're looking at it on a rhythm strip, you're going to have these big boxes. And each big box represents about 0.2 of a second. So that means each little box represents 0.4 seconds of time. So first of all, one of the things you need to do when you look at an EKG is determine first what type of rhythm. Is it sinus rhythm? Sinus rhythm means that the SA node is pacing the heart. Now, it doesn't mean it's normal sinus rhythm, but you know that the SA node is the primary pacemaker of the heart, and it intrinsically fires at a rate of about 60 to 80 times per minute. That's why the normal heart rate is between 60 and 80 beats per minute. It can vary a little bit, but that's its intrinsic rate. Other factors, sympathetic, parasympathetic stimulation. But when it fires, because you remember that the right and left atria function as a unit, and because the heart cells are connected by gap junctions and intercalated discs, when the SA node produces this electrical impulse, it spreads instantly over both the right and left atria. And then that's atrial depolarization, and it's going to produce the P wave on the EKG. Now, for the most part, especially if you're looking at lead 2, the P wave should be positive, and it should follow the direction of the QRS. So if the P wave is positive, the QRS should be positive, or vice versa. Now, you also recall that you don't want the atria and ventricles to contract at the same time. That's why, and illustrated by these smiley faces, is what I like to call the little rubber washer that separates the atria from the ventricle. And basically, it prevents the electrical impulses that were generated by the SA node from going directly to the ventricle. It also allows for the atria to contract and push that additional blood into the ventricle, so it allows for atrial kick. So once those electrical impulses have spread through both the right and left atria, then because of the little rubber washer, the smiley faces, that electrical impulse can't go directly to the ventricles. So instead, it's funneled into the next portion of the electrical conduction system, and that's called the AV node, or atrioventricular node. Now, the AV node can also act as a pacemaker of the heart. But if you recall, the AV node has a lower resting membrane potential than the SA node, so it takes longer to reach threshold to fire. So if the SA node has got a problem, then the AV node is going to take over as the pacemaker. And the intrinsic rate for the AV node is about 40 to 60 beats per minute, right? It fires at a rate of about 40 to 60 times a minute. So that means typically that your heart rate is going to drop. Also, in some cases, you're going to lose the effect of atrial kick. So people who go into a junctional rhythm may become symptomatic. So when you hear the term junctional rhythm, what you should immediately think is that the SA node ain't the pacemaker of the heart. Instead, it's the AV node. Now, if we look at that, and let's look at that just for a minute, maybe. Hang on. Where is it? smiley faces there. So this is lead 2, what you're looking at. And what can happen in a junctional rhythm is, number one, you're going to get a lowering of the heart rate. Excuse me, it's the pure junctional rhythm. And the P wave, what will happen is, number one, it can actually disappear. It can be depolarizing at the same time as the QRS. So you may not be able to see the P wave, but the QRS in a junctional rhythm is going to be a normal QRS because it's still going through the bundle of His, left and right bundle branch, and the Purkinje fibers. So the QRS complex, the depolarization of the ventricles in a junctional rhythm, is unaffected. The thing that is affected is the heart rate. The other thing that can happen is you can get what's called retrograde depolarization of the atria, where, if you recall, when electrical impulses go towards a lead, so if we go back here for a minute, lead 2 looks at the heart kind of like this, right? So the positive electrode for lead 2 is here, and the negative electrode is here. So anytime electrical impulses go towards the lead, it's going to produce a positive deflection. So when the SA node fires, those electrical impulses are going to be traveling towards this positive lead. That's why the P wave is positive. And then when the ventricle is depolarized, because the left ventricle is stronger, it's going to pull those voltages towards the positive lead 2, and that's why the QRS should be positive. Now, if we look, when the AV node takes over as the pacemaker, right? Yeah. Right? When the AV node takes over as the pacemaker, it's going to fire, and it's going to send the electrical impulse through the bundle of His, left and right bundle branch, and Purkinje fibers. So if you're looking again at lead 2, then what you're going to see is you're going to see a normal QRS, right? Because it's going towards positive lead 2. But what can happen in people who have a junctional rhythm is that the QRS can be depolarized, right? The ventricles can be polarizing at the same time the atria are depolarizing. So you're not going to see the P wave. Or in some cases, when the AV node fires, what will happen is it will retrograde, or it will go back to depolarize the atria. Now, if you look in lead 2, because these electrical impulses are going away from lead 2, it's going to produce a negative P wave. And because you no longer have that delay in the AV node to allow the atria to contract, you're going to have an inverted P wave, and the PR interval is going to be shorter than normal. So that's the example here. Let's get rid of that. So what's happening here, remember the rate, this is a junctional rhythm, so the rate is going to be between 40 and 60. And then the P wave is buried within the QRS, and the QRS and the T wave are normal. In this one, you have what's called a retrograde depolarization of the P wave. And the PR interval is shorter, and the P wave is negative because the AV node is depolarizing the atria, and the electrical impulses are going away from it. Another one is you'll have the QRS complex, and then you'll actually have the P wave after the QRS, and it'll be negative because it depolarizes after the ventricles have depolarized. These two conditions are more likely to occur. I haven't seen too many of these where you have the P wave depolarizing after the ventricles. So that's a junctional rhythm. Now, of course, you can have variations on that theme, right? You can have what's called an accelerated junctional rhythm. So in this case, the AV node is firing at a faster than normal rate. Now, what's important to remember and how to differentiate that is the R to R interval is going to be consistent, it's going to be regular, but you won't be able to see any P waves. In this case, you can kind of see a P wave here, right here, but it's kind of embedded in the QRS, and the PR interval is definitely shorter. So this is what's referred to as a junctional tachycardia, and or it's called a supraventricular tachycardia, because supraventricular, supra means above the ventricle. So how do you know it's not being initiated by the ventricle? Because the QRS complex is of normal width, right? It's a normal looking QRS. So you know that that impulse has to be coming from above the ventricles, either the SA node or the AV node. In this case, because the PR interval is shortened, you know that this is a junctional tachycardia. So if you were to do this, if you were to write supraventricular tachycardia as a broad class, you could put atrial tachycardia, right? Or junctional tachycardia, right? As two subclasses of what's called supraventricular tachycardia. And for the most part, whether it be atrial or junctional tachycardia, they're treated the same way. So that is a junctional rhythm, and accelerated junctional rhythm or junctional tachycardia, right? And then here's an example of a supraventricular tachycardia or a junctional tachycardia. And these rates typically get above 150. They can go as high as 150 to 250. That could be an atrial tachycardia or a junctional tachycardia. Again, to determine where the electrical impulse is coming from, you have to look at the QRS complex. And is the QRS complex, is it of normal width? The answer is yes. So you know that that electrical impulse that's initiating this rapid heartbeat is coming from above the atria. All right. Now, a couple of other things too. You look at this one. This is atrial fibrillation. Now, normally, in a normal EKG, if it's sinus, then you're going to have a P wave, and then you're going to have the QRS and the T wave. Then you're going to have the P wave, QRS, and T wave, right? And it should be regular. That's sinus rhythm. But in this case, the atria are firing willy-nilly. So you see this kind of like real scratchy looking baseline, and then you see a relatively normal looking QRS, at least in terms of its width. And if you were to also measure out the R to R interval, you'll find that it's irregular. So if we turn to our little heart here, what's happening in atrial fibrillation is many atrial cells are firing off electrical impulses rapidly, and they're typically at a rate of like 250 to 350 times per minute, right? Now look, the AV node is kind of like the guard for the ventricles. It only lets a certain number of impulses, electrical impulses, through to the ventricle. So the atria are firing off these various electrical impulses. That's going to produce the kind of like the goofy looking baseline. And then every once in a while, one of those impulses is going to be allowed to go through to the ventricles and cause the ventricles to depolarize, right? Now, in people who are in atrial fibrillation, right, if they've been in it long enough, you know, for, I don't know, 3 months, 6 months, it's very unlikely that you're going to be able to pull them out of it. If they've only been in it for a day or two, there's a good chance that you can pull them out of it. And a lot of times, like digoxin or beta blockers can be given to slow that down. But if a person's in atrial fib and they've been in it for a while, they're always going to be in it. So what the physician wants to do is to make sure that the ventricular response is controlled. The problem arises in people with atrial fibrillation is that if too many of these electrical impulses are allowed to go through, then the ventricular rate gets really high. So what happens there is two things. One, you're already losing atrial kick, which is 20 to 25% of your total blood flow. And now the ventricles are contracting like crazy because the AV node is letting all those electrical impulses through to cause the ventricles to depolarize. So the atrial rate the ventricular rate gets really, really high, and it doesn't allow the ventricles to fill, so the people's blood pressure drops. So what a physician wants to do is they want to be able to control that ventricular response. So how you differentiate atrial fibrillation from other arrhythmias is the fact that the QRS complex, the interval is going to be irregular, right? So you got a kind of this goofy, kind of nasty looking baseline where the atrial cells are just depolarizing. Then every once in a while, the AV node lets one through. So you get a normal ventricular QRS complex, but the R to R interval is abnormal. And most of the time, the goal of the physician is to keep the ventricular rate in people with atrial fibrillation under less than 100 beats per minute. So that's atrial fibrillation. Now, there's a condition called atrial flutter. This is classic. You get the sawtooth approach here. So little saw teeth. My little ink thing is really jacking up. But you get the idea of these little saw teeth, right? Now, in atrial flutter, the atrial rate is fast. It can be as fast as 250 to 300, right? So you're getting these rapid depolarization of the atria. But in this case, what's happening is you're getting electrical impulses, right? And they're firing rapidly. And the atria, or the AV node, is only allowing a certain number of those atrial impulses to get to the ventricles. So in atrial flutter, you're going to see the sawtooth. And what's important to remember is atrial flutter usually occurs in rates of like 3 to 1 or 2 to 1, right? But the ventricular response is usually regular, meaning the R to R interval is regular. And you always suspect atrial flutter of 2 to 1 conduction if the heart rate's about 150 and you see just 2 saw teeth. In this case, you see 3 little saw teeth. So the rate of the conduction rate is like 3 to 1. So this is a real quick and dirty version of some junctional and atrial arrhythmias. And I hope that